Welcome. This is Resilience Radio. Who am I? I'm Irvin Eisenberg, show host and owner of Resilience Occupational Therapy. As always, the opinions on this show are not necessarily shared by me. I like to feature a variety of different perspectives, and not every healthcare suggestion or approach is appropriate for everyone. Additionally, none of this is meant to be medically prescriptive or diagnostic in any way. My guest today is Sienna Flanders. She's a home birth midwife and owner of 8 Generations Birth Services. As a personal disclaimer, she was the midwife for the birth of my child, and me and my wife are very appreciative of that. It's great to have you on today, Sienna.
Thanks. It's great to be here.
So I wanted to start off just if you could share a little bit about what drew you to home births and midwifery.
Sure. My kids are 23, 19, and 17. They were all born at home. Oddly, I was 26 when I had my first and was not a midwife. Had never thought of being a midwife. What drew me to having a home birth myself was the story of my birth was my mom being driven to the hospital from Calais to St. Johnsbury in a snowstorm and having to get out and pee on the side of the road a bunch of times. And that was a story that I had always heard growing up. And I just didn't want to have to get in a car. So I really hadn't done a ton of research around to begin with. That was what sparked kind of the idea of just staying home. And then obviously when I got pregnant, I started doing more research and we decided to have our kids at home, which we were able to do. After my first was born, I thought kind of one of those real quiet little voices in the back of your brain, like, maybe I want to be a midwife. But I thought probably everybody feels that when they've had this kind of an experience. And I'll just ignore that. And I did solidly, completely, 100%. Didn't hear that voice again at all for 10 years. And then some shifting happened in our family with, where kids were going to school. We had been homeschooling. My oldest started school. And it was like, as soon as that tiny crack, I still had 2 little ones at home full time, but that little bit of space in my life or shifting in my life, that voice came back loud. And so I called a friend of mine who had been a student midwife at my second 2 births, and neighbor Bonnie Dunham. And she was now a licensed midwife herself. And I asked her if she wanted to take on a student. And she agreed. So that's kind of where it started. I had never been to another person's birth. I didn't know if, it was one of those things like I'm feeling clearly drawn to this, but I don't actually have any experience with it other than my own. So maybe I'll go to a birth and realize that is not for me. But that's not what happened. The first birth that I went to with Bonnie and Autumn, both midwives. So I was really there, as the newbie to the experience that I was. But I felt confident and comfortable and like I needed to learn a whole lot, but that was something that I really truly did want to do.
Mm-hmm.
So
can you speak to what that training process looks like for home birth midwives?
Yeah. There are a couple of different kinds of midwives, but I'll speak to sort of my path, which is a certified professional midwife and licensed midwife here in Vermont. So that path can look like there is what's called a PEP process that's kind of fading out in some places. that is more of a self-guided educational process for the school work part of it. What I did was go to a MEEC accredited school. Often these are distance learning programs. There was Birthwise was a school in Maine for many, many years that was in person. And they just closed maybe 2 years ago now. So most of the programs that I'm aware of are distance learning programs. I also did, so that, that's for like the book learning piece of things. And then there are clinicals that you're required to do. So there are 3 phases. There's an observe phase, an assistant phase, and then a primary under supervision phase. Those are for prenatals, births, postpartums, and then there's a specific skill set that you have to get checked off as well by 2 supervising midwives. You have to take, I believe, this is my recollection, it has to take at least 2 years for you to do all of your clinicals. You can't do it in less than that. Mm-hmm. But you can pretty much, I think there's something about 5 years. If you're taking longer than 5 years, you might need to get like a exemption or acknowledgement of that or something. But, I know people that have been studying over the course of 10 years, kind of, off and on or things like that. Mm-hmm. And once you have all of your clinicals signed off, then you can sit for the exam. So it's a nationwide certified professional midwife certificate that you sit for. It's usually given in 2 2-hour sessions, so a 4-hour exam. Not that you have to take that long, but that's how long you get.
Okay. So I think there's a lot of people have narratives of what birth is about. And the classic thing we see on TV is everything's done in a hospital unless you happen to accidentally like give birth on the way to the hospital, or you don't have a chance to get there for some reason. And that's like the safest, best way for that to be. And I feel like that's the narrative of fear of a home birth, that's only something that should happen under like duress. And I know there's just a lot of fears around that. I'm obviously biased, having chosen a home birth in this, but could you speak to the what the risk factors are in a home birth, and what's its sort of its benefits and its risks?
Sure. Yeah. I think for a lot of people, the idea of home birth, like you said, is, either whoops, the baby came out before we were expecting, or, there's a gray-haired lady knitting in the corner. And that's the midwife. I am getting some gray hairs, but, and I do knit a little bit, not very good at it. The true, currently, and again, it varies country to country. In the United States is a complicated web of differences. In some states, like Vermont, we're legal. Massachusetts is considered an illegal state. There's no law saying home birth midwifery is illegal, but there's also no laws saying it is legal and you have to follow these rules and guidelines. And then some places there are laws where it is illegal. For me, and there are, of course, different arguments to be made and different reasonings. For me, I feel most comfortable in a state like Vermont, where we are legal. We do have rules and regulations that govern our practices. For some people, that feels restrictive. For me, it is a compromise. We can't do breech at home. We can't do twins at home. And there are other conditions that we can't care for at home. And it also, on the other side, it allows, we do have a formulary, and we are allowed to carry antihemorrhagic medicines, Pitocin, Methergin, Misoprostol. We are allowed to acquire and administer IV antibiotics during labor if those are recommended or warranted. We carry oxygen. We carry, those are kind of the main big ones, I think. So being able to carry those, being able to, and having been licensed, our licensing is over 20 years old now. We've been around the regular medical establishment for that long, and we're pretty integrated. Not quite like Canada or the UK, but I can call Dartmouth or UVM 24/7. They have on-call providers, and I can call and consult. And especially up at UVM, they know me, they know my practice. They're not just going to say, oh, home birth, oh my gosh, no, bring them in right away. Like, I can actually get a true, genuine consultation about what is going on and whether it is safe to proceed it with home birth care. And I'm talking also about things that crop up prenatally, not that are an emergent issue at that moment, but what, this is what I'm seeing in the office. What, I haven't dealt with this before. I have a client right now that is going to be getting an iron infusion for her to treat her anemia, which is something I've never done before. And I was able to just, access the hospital system, couple phone calls, get that set up. So for me, the trade-off of having some restrictions on my practice, but also having the access and continuity with medical care when we need it, feels well worth it. Mm-hmm. Your question was more about sort of the safety of home birth. I guess that's where I'm going with this is, for me, that makes home birth a lot safer. Having a trained attendant. I was trained, obviously I attend, well, I don't know about obviously, but I attend when my clients need to deliver in the hospital. I continue my care and attend with them in the hospital. I don't have privileges, but I'm considered part of the medical team. So I do attend hospital births, and I did so in my training as well. But my training was really all focused on out of hospital birth. So this is my specialty. All of my training was focused on how to recognize normal versus not normal in all of the stages of the perinatal period, and how to support and encourage, create an environment that supports women giving birth unmedicated at home. So I'm used to seeing women work hard. I'm used to seeing them in discomfort. And I'm pretty good at judging the difference between hard work and suffering. And I think I see a lot of times when I am in the hospital, or, I have friends that are L&D nurses and nurse midwives, and I hear a lot of times, for the most part, epidurals are used quite frequently. At least, I'm thinking of UVM in particular. Community hospitals are a little bit different. They're kind of somewhere in between in certain ways, and depends on the hospital. But a lot of OBs and nurse midwives and hospital nurses aren't, what you do becomes normal. So if they're used to seeing people with epidurals, when they see someone working through an unmedicated labor, it can be alarming to them. I've heard doctors say, like, is this okay? I think she needs some relief. And if a birthing person needs pain relief, I'm all for it. Absolutely. But when it's the provider's discomfort or unfamiliarity with what it can look like to give birth without pain medication, that's where I think it gets complicated. And so it's all a long-winded way of saying, in terms of safety for home birth in Vermont, we're well integrated at the medical system if we need those tools. Most of the time we don't. And giving birth in your own home with your own comfort measures, in your own space with a provider that is trained in supporting birth in that environment, with the tools that we have at hand, and recognizing when that's no longer the best or safest option, and being able to help change gears when needed, is very safe.
So I think people are like the idea of having the hospital close at hand, and that changing gears, but you're changing gears, but you're far away from the hospital, or potentially. Could you speak to the time frame of that, of when things go wrong, when things require a hospital? What's that transition
Yeah.
look like?
The very most, there are other cases, of course, but for the most part, and this is true for me and true for, home birth midwives statistically as well, the vast majority of our transfers to hospital are first time laboring people, and it's the opposite of an emergency. We just can't get from here to there with the tools that we have. These are usually longer labors. Something has gone out of balance, whether it's hydration, exhaustion, functionality of the uterus. It is a muscle. At term, it's the strongest muscle in a woman's body, which is kind of cool to know. And baby's positioning, and coping abilities. Like those are kind of generally the pieces that are in motion, and we may start to see them go out of balance. And when we see that, we start to talk about it and say, this is that scenario that we talked about, that, we might need to go to the hospital. Usually it's Pitocin to get stronger contractions, or nitrous if a hospital has it, and or an epidural. For nitrous can be helpful if we're very close to delivery. But if someone really is clinically exhausted and needs to actually sleep, an epidural is usually much more effective for that. So those are generally the tools that we're needing if we go in. And we talk about it ahead of time. We see it coming. Usually with my clients, I may have had that conversation a couple of times. Like, this might be that situation where we need to go in, but clinically right now, birthing person and baby are both looking really good. So if we want to go in now, we can. If we want to spend another 3 or 4 hours, let's try A, B, C, and D, and then 1, 2, 3, and 4, and regroup and see where we're at in 3 or 4 hours. In those situations, we can always transfer by ambulance if that feels safest. But in this situation, typically people decline ambulance and we go in our own vehicles. I call the hospital ahead of time, tell them what's happening. I fax over all of the records so they have all of that clinical information that they need about the person before we even walk in the door. And and then we go together, and I stay with my client, supporting and helping them understand and navigate the situation as it progresses till baby's born. And then when they go home, we resume the postpartum care that we would normally have planned anyway.
I remember when we were going through birth planning process with you, how I was impressed and very much put at ease by the fact that we had a plan for what a hospital birth would look like. We met with the surgical practice that would be doing the cesarean, and had written up birth plan for if things were to transition to hospital under certain circumstances. We had sort of our plan A, B, and C, and with exception of like a really premature delivery that would result in like need for Dartmouth or UVM. I can't remember which we had chosen for that stage. It wouldn't have felt like a failure, at least at that point. I don't know how the emotions would have felt it was like, oh wow, this is a supportive environment and we could do this here as well. It's just not our preference. So I really appreciate that continuum of care, and I imagine that's not really available in states where the licensure is different, or there is no licensure, like Massachusetts, you're saying?
Correct. Yeah, I can't speak too specifically to Massachusetts. I don't know. I don't have any close relationships with any Massachusetts midwives. I've met them, but I don't know what their reception is in their local hospitals. I do know I have friends in other states around the country where it is either illegal or certainly illegal, where yes, they can't go into the hospital with their clients when their clients go in, or if they do, it's a somewhat hostile collaboration, if collaboration is even the right word at that time. Um, yeah, yeah, I really, really appreciate um, the access that we have to all of those tools. A couple catchphrases that I use. I tell my clients, um, I don't care. I love what I do. I had my babies at home. I'm a home birth midwife. I believe in home birth. But to me, that isn't really about the walls that are around someone when their baby comes out of their body. It's about the quality of care that I can give and the time that I can spend building a relationship and the support that I can give wherever the birthing ends up happening. Um, and I think that really does, yeah, I agree with you. The phrase, failed home birth doesn't really register for me. Unless there was some sort of catastrophic failure in care. But going to the hospital does not connote with a home birth failure to me. We start out at home. The other way I think about it is most people go into labor at home and have to decide kind of on their own, talking to a triage nurse maybe, when to go into the hospital. And for me, my clients go into labor at home. They call me, I come to them at home. We stay and have a baby most of the time. But if that's not the case, then I'm there to help them know when it is time to go to the hospital and to help make that feel less. I'm not saying anybody likes to transfer, but having me there, I think, helps bridge the gap. And they have that continuity of care. They know that they have a relationship with me. I can help them understand what are the things in the hospital that are maybe they're just offering because they're routine and they aren't necessarily pertinent to this person's care, or no, these are tools. One that I think is an interesting one is what's called a fetal scalp electrode, which is a little teeny tiny wire. It's about as thick as a hair, maybe. I think it's even thinner than that. That can be placed. The water bags have to be broken already, but it can be placed in the scalp of the fetus's head to monitor the heartbeat. And to a lot of people, that feels really invasive. And certainly, if you don't need it, then you don't need it, and that's great. But if we're having, for whatever reason, a hard time listening to the baby's heartbeat, well, it can be kind of, yes, this is invasive, but it also might give us the information that the team needs to calm down and not be on high alert. And so it can be, I think, a useful tool sometimes. But having me there, having the relationship with me, knowing that I'm not just trying to do things the way, I think sometimes people feel in the hospital that it's hard to tell whether something's being offered because what would the usefulness of it be? Sometimes it just feels like you're kind of on a train and the providers are saying and now we're going to do this and now we're going to do this. So I think helping folks navigate that is also, a real gift of the work that I do.
Yeah, and I think about healthcare systems in general in the hospital. If people have the procedure of how they do things, even if something doesn't seem like it's maybe the most useful for your individual care, that I can see people being worried that they're going to be treated differently if they don't accept something, or people are going to be caught off guard because they're used to that particular assembly line, where it's well, I could see someone choosing, I want to have an epidural because I want them to be dealing with what they normally deal with. I want them to be able to recognize when something isn't right versus be freaked out as physicians. Right. So having the more nuanced approach, who knows the person's birth plan, knows the need, and can have a different set of normal present in the hospital, I could definitely see that pairing well together under at least some circumstances.
Totally.
So I'm wondering if you could speak to the decision-making process as to whether or not to have a home birth or hospital birth, and Yeah. If you could speak to that decision-making process and how you've helped people through that, and what might be indicators that a home birth is right for you or not right for you.
I've worked with folks that have had hospital births previously and then come to home birth. I've worked with folks that, like yourselves, that, wanted a home birth. Knew that kind of going in. So yeah, there's all kinds of different questions that people make. It really, for me, most of the people that are inquiring, the vast majority of people that are coming in and inquiring about home birth with me are great candidates in terms of low risk, healthy, normal pregnancies. Not everyone stays there through the whole pregnancy, but most people start out that way. So that's kind of the first level, is just sort of medical screening. Is this a birth that feels appropriate to be out of hospital? There are certain conditions like thyroid conditions, heart conditions, pre-existing diabetes, things like that really are, in my mind, not best suited for home birth. So the first is kind of that level of like medical assessment. And then it's really what someone wants, and what, do they want an unmedicated birth? Where do they feel most comfortable? For most people, if they've had experiences in the hospital, those experiences have been because someone was sick or injured. So a lot of people kind of have negative connotations with being in the hospital, and want their birth to not be associated with that if it's not necessary. And then there's, there's all the stuff that just is the warm, fuzzy part of home birth, right? You're in your own home. You can eat your own foods. You can move how you want. You can be inside or outside. I support water birth. My clients have access to the birth tubs that I have. So there's the one-on-one relationship that I build with my clients. And then I do have protocols and guidelines, particularly around the clinical and medical pieces, but I don't have the same kinds of protocols on the birthing floor. People can move however they want, be wherever they want in their house. So those are, it really usually comes down to, where do people feel safest and most comfortable? And for some people that is the hospital, and that's great. I'm glad that they have, that they have that opportunity. I also want people who that's not true for to have the opportunity to have a provider, a trained, skilled provider at home with them if that's what they choose.
Well, I think we've chatted before about, I think during COVID there was a lot of people who were, for fear-based reasons, wanted a home birth, for understandably not wanting that exposure. And I think you were just talking a little bit about the fact that it wasn't the right reason to have a home birth for some of them. And
right.
I don't know if you could speak to sort of the right reasons versus the not right reasons for a home birth.
Yeah, I think the simple way for me to put it is, if it feels like someone's running from something versus running to it. If someone is drawn to home birth, feels like it would be safest for them, most comfortable for them, feels that they don't plan to need pain support or medication in the pharmaceutical range. I guess that the easy way I would put it would be like strength-based reasons. Then that's a great conversation to have and dig into with people. it was more prevalent during COVID, especially that first year, that I was having more people interview, and it wasn't so much about I want a home birth as it was I don't want to have to go to the hospital under these conditions. And hiring me as a home birth midwife, planning a home birth with me doesn't guarantee that we're not going to the hospital. That is not, as we've discussed quite at length now, there's no guarantee. We make our plans, and then we deal with how the labor is unfolding and the birthing process is unfolding, and we make the best decisions for health and safety as that unfolds. And I do have clients that I have worked with that did have strong and do have strong feelings about the hospital, or negative associations with the hospital. If that's an adjunct to really wanting a home birth and really moving towards a home birth and strength base, that's something that I can work with. That's something that we can talk about. And there are various strategies depending on what a certain person's needs and preferences are. Maybe we would talk about, if possible, going to a different hospital than the hospital that they had a hard situation in, or meeting providers ahead of time, as you guys did. How can we demystify it? How can we make it feel as good of an option as possible if it's needed? Mm-hmm. But mostly, COVID aside, not exclusively, but mostly the people that seek out my care are good home birth candidates, and drawn to it either because, I have, at this point, which is really fun, I have clients who were born at home themselves. So it's always kind of been on their radar, or they have friends or relatives that have birthed at home. I would say, I don't have a statistic, but I would say probably well over half of my clients kind of fall into that category, know someone, close to them, that had a home birth, and have it in their wheelhouse in that way.
Yeah, and I'll speak personally to that for me, I was my mother's fourth home birth, and it was just part of sort of the narrative in for me of like what you do. And these hospital births that I would see on TV always seemed odd to me, just because it wasn't in sort of my worldview. And I had the probably not entirely fair narrative that my birth itself, I was born in the embryonic sac still, and I came out and the cord was wrapped around my neck. And people go, "Oh, the cord is wrapped around your neck. You probably should have been in a hospital." And the story I hear as well, the midwife broke that. The call was preventing the cord from strangling me, and that maybe I would have had some brain damage had I been a hospital birth. Probably not fair to the skills of hospital nurses, doctors, and midwives, but sort of the narrative I had, it was a good thing I was born at home because it was safer. But I feel like everyone comes at them with their own birth narratives of either their own birth stories or the stories they hear and consume in media. Can you speak to like the variety of birth narratives and how the reality of birth might differ from some of the more dramatized versions?
Yeah. I mean, we're talking about Hollywood. It's remarkable how poorly and over dramatized so many of the births that we see are. It is remarkable, but it's also not, right? Because that's what TV and movies are. They're entertainment, they're drama. It's not that exciting to be with someone for 36 hours laboring and then they have a baby in the tub, and there's like that just wouldn't make for a very good movie. um, in terms of people's personal narratives, it is really, I don't even know, it's very interesting. There is a lot of fear. There's a lot of fear and a lot of drama, and sort of like, even whichever way it goes, like your story is that thank goodness you were at home because it could have been really dangerous to be in the hospital. And then of course many people have stories of well, thank goodness we were in the hospital because this would have been so dangerous at home. I think that's kind of the germ maybe of CPM training, is seeing home birth after home birth after home birth, seeing relatively at least unintervened with unmedicated births. You get this really large sense of normal, and a lot can happen. And there can be, cords around the neck, or slower labors, or stalls in labor. Like labor can look so many different ways. Birthing can look so many different ways and be completely normal. And I think that's the real gift of my training and my experience, is I can hold that space. And ideally, my favorite thing is leaving a birth. And I do hear this often, like I'm tucking them in bed, I'm leaving the birthing space, and I hear them saying, wow, we did that. Yes, you did. It's not about me as the provider. And I think so often that's where these fear-based narratives come from, is kind of the ego of the provider creating and leaning into that kind of a narrative of sort of, yes, if I hadn't been here to help you in this way, this could have been horrible and scary and awful. And my, is there occasions that I'm really glad that I was there to provide whatever skill I had that seemed to be needed? Sure. But that's really pretty far and few between. Mostly I'm there to help remind people that this is all normal and you're doing great, and keep doing what you're doing and have a baby. And that it doesn't have to be a lot of drama and a lot of fear. I mean, some, emotions come up, right? It's a rite of passage. It's a huge shift. It's it's a ceremony, whether we create it or think of it that way or not. And so, yeah, emotions can come up. People can, birthing people and their partners and attendants, whoever's there, hopefully not the attendants that are clinically working, but emotions can come up, fears can come up, all of that stuff is welcome. Whatever is coming up for the birthing people, for me, is welcome in the birthing space. And my job is to, as I see it, is to like help normalize that. Yeah, it makes sense to be scared. This is really hard work and you've never done it before, even if you have done it before, but to not to like, oh, you seem scared, something must be wrong. Like, obviously I'm listening to people. If they feel concerned that something is wrong, I'm going to listen to that concern. But if it's just normal emotions, let's talk about it and share it and let it go and keep going.
Well, I think that's a great note to go out on. Thank you so much for coming on today. I really appreciate your time and sharing your experience.
Thanks for having me. It was great to get to spend some time with you again.
That was Sienna Flanders, and this is Irvin Eisenberg. I hope you enjoyed Resilience Radio. Thank you to Aaron Marcus for the music on this show. With their tune, Some Biological Process, you can check out the show notes for full credits on that. Until next week, take care.